Okay, good morning for all of you hardy people who have stayed through all of this. So this has been, I think, a great educational experience, the whole program. Professor Kanat has put together, I think, an outstanding, program. Covers all aspects of diabetes, and I think we all look forward to coming back next year. Mustafa, where are we going to come back? Have you decided? Okay. He likes Bodrum. I like Bodrum. Okay. So it says maybe we'll be back here in Bodrum. I have to say, this is a spectacular place. You just come here and everything is just here. You don't have to do anything else. So this is my last talk. I said to Mustafa, how come you only gave me 5 talks to present this time? So he said, next time I make you 6 or 7. I said, all right, okay. So we're going to talk about SGLT2 inhibitors, and this is a very unique class of drugs. So I actually invented this class of drugs, and this year, actually 1 week from now, I will give the Barry Brenner Memorial Lecture at the American Society of Nephrology meeting for inventing this class of drugs. So I like this class of drugs, and I have to say, when I first started working with the SGLT2 inhibitors, my intent was to develop them as drugs that lowered glucose and were good for glucose control. I also, from my nephrology background, was aware that these drugs probably could be developed as renal protective drugs. But I have to say, I had absolutely no idea that they would have such cardiovascular benefit. So as I take you through this story, you're going to see we have a great drug for glycemic control, a great drug for preserving a kidney, and a great drug for preserving the heart. So these are really a wonderful class of drugs for our diabetic patients. So where does the story start? The story starts with this molecule called fluorescein, and fluorescein comes from the bark of the apple trees when the apple trees bloom in the spring. And when I was a renal fellow at the University of Pennsylvania, I was trained as a micropuncturist. So I put small little pipettes into tubules, and I was particularly interested in sodium and glucose transport and how insulin regulated sodium and glucose transport in the proximal tubule. And at this time, I recognized that there was this drug called fluorescein that blocked not only sodium, but blocked glucose transport. So the original studies that I carried out actually were done when I was a nephrology fellow, but it was clear to me that this class of drugs would be a very, very good class of drugs to treat diabetic patients. And the idea is so simple that no one thought about it. Here you have a drug, you just give it to the kidney puts the glucose out in the urine, and your blood sugar comes down. Very simple, but no one thought about it, okay? And you can see at the bottom, all the original studies were done around 1989 to 1991. And we looked at a number of animal models, OB mouse, DB, etc. And all of these diabetic animals, we treated them with this molecule called fluorescein. And fluorescein is a combined SGL2, SGLT1 transporter. And the S is for sodium, the GL for glucose, T transporter. And when you block those transporters, the glucose comes out in the urine, the blood sugar level comes down, and what we saw was that there was a major improvement in insulin sensitivity in these rodents. And then we also looked at the molecular mechanism. There was a big improvement in the insulin signaling transduction pathway and a big improvement in GLUT4. So these early steps in glucose metabolism were markedly upregulated, and there was also a major improvement in insulin secretion. So these were very encouraging, but as I say, the one thing that mice and men have in common is they both start with the letter M. But they're really very different. So what we wanted to know is these really wonderful stories that we was developing in the mice, did these results fit? Could they extrapolate to humans? So this is actually the very, very first study published using dapagliflozin or any of the SGLT2 inhibitors looking at these drugs in humans. And we only needed to study a small number of people because we knew that this class of drugs was very, very effective. And we were using very sensitive methods, the insulin clamp, the hyperglycemic clamp. So there were 12 people randomized to dapagliflozin, 6 people who were randomized to the placebo group. You can tell the study's done in the United States. The BMI is 34, and the starting A1C is 8. So these are very typical people with type 2 diabetes. So what happened? In this original study, which was published in the JCI, you can see in the first panel, the fasting glucose fell by about 30 milligram per deciliter. The increment in glucose rise above baseline fell by 40. And so the 2-hour glucose, which is the third panel, fell by about 70. So the drug was quite effective in humans, not as effective as in the rats where we completely normalized glucose tolerance, but clearly a very effective medication. So then in these studies, we also wanted to know, how is the drug working? And so during the OGTT, we looked at the rise in C-peptide per rise in glucose. And this gives us an index of insulin secretion. As you can see, we literally doubled insulin secretion. Now, the SGLT2 inhibitor is only present in the kidney. So this cannot be a direct effect on the beta cell. This is the first demonstration in humans of the glucotoxicity hypothesis, which we presented many, many years ago. So just simply lowering the glucose without doing anything else doubled your beta cell function. So it shows you that chronic hyperglycemia is not good for the beta cell. And then in the middle, we did an insulin clamp. You know, we infuse insulin, and then using radiolabeled glucose, we quantitate how much glucose is taken up by all the tissues in the body. Insulin sensitivity improved by about 35%. And then to the far right in orange is the gold standard for beta cell function. So insulin secretion, just measure how much insulin comes out. Beta cell function, you have to measure how much insulin comes out and express it per how insulin resistant the person is. Because if you're very insulin resistant, the beta cell will read that and it will secrete more insulin. If you're very sensitive to the insulin, your beta cell doesn't have to secrete much insulin. But you can see we doubled that gold standard index of beta cell function. So we knew that this was going to be an effective drug, and this was the first documentation of approval of the glucotoxicity hypothesis. But then we wanted to know, and we pretty much knew the answer, once you block SGLT2 inhibitor by transporter, by any drug, you should get the same results. So we said, let's take a look and see if we get the same result with empagliflozin. And you can see here, if we look at the increase in insulin secretion at baseline, in the middle, the insulin resistance index from the insulin clamp, in the bottom, the beta cell function index, you see within 2 days how remarkable the improvement in insulin secretion, insulin sensitivity, beta cell function, and this persists for 14 days. We've published many data. These effects persist for up to 6 to 12 months. So I basically believe that all SGLT2 inhibitors are created equally. They basically do the same thing. And if you see little differences that are published in the literature, and generally the differences are due to the patient population, not to the drug. So I'm not going to take you through the ominous octet again, because you all know what the ominous octet is, but I'm just going to show you where these drugs work. The primary effect of the SGLT2 inhibitors is on the kidney. And when you open that spigot and the glucose comes out in the urine and the blood sugar comes down, you improve insulin sensitivity in the muscle, and I already told you this is due to upregulation of the insulin signaling pathway in the GLUT4 transporter, and you improve beta cell function. So we're correcting 3 of the problems in the ominous octet. This is going to be a very good drug or a class of drugs for treatment of people with type 2 diabetes. Now, how do these drugs work at the level of the kidney? And this was another interesting sort of flight through space, so to speak, because we discovered a whole lot of things that we didn't know and that people didn't know. So I take you back to your renal physiology days. You all learned this at one point in time. Fasting glucose, the mean day-long glucose, about 100. GFR, 180 liters per day. So you filter about 180 grams of glucose every day. So how much of that glucose appears here down in the urine? None of it appears in the urine. And why is that? Because in the early proximal tubule, there's this SGLT2 transporter, and that transporter takes back 90% of the filtered glucose. And if it does its job, this SGLT1 transporter that's downstream will take back the other 10%. So what I'm going to show you is that this transport system becomes markedly dysregulated in people with type 2 diabetes. So the second part of today's renal physiology lesson has to do with this concept of the renal threshold, and I took you through this before, so repetition, I think, is always a little bit good. So we start with a fasting glucose of 100. I infuse glucose. I raise your blood sugar to 180, and you can see no glucose comes out in the urine. But once I get to the renal threshold, all of the glucose that's filtered above that comes out in the urine, and this is in you or I. We have an A1C of 5, and the paper is shown up here. And you can see this is an old paper. It's 2013. So these drugs now have been around for a long time. So what happens if you become diabetic and your A1C is 6.5? You can see this threshold is already increased. It's not 180, it's 205, and so forth. As the person becomes more diabetic, A1C 7.5, 8.5, 9.5, this threshold goes up quite dramatically. So now, in this very, very poorly controlled diabetic who's filtering a lot of glucose, that glucose is not showing up in the urine. Why? Because the kidney, paradoxically, is holding on to the glucose, okay? And I mentioned this the other day. Remember when we were young and we were interns, we used to measure the urine glucose and then decide how much insulin to give. Now, of course, that was ridiculous. That's why people never got controlled in the old days with insulin therapy. So, how do the SGLT2 inhibitors work, okay? And why is it that that glucose, which is filtered in a very large amount, does not appear in the urine? So we looked at people with type 2 diabetes, and we did renal biopsies in them and compared, and we isolated the tissue, and we measured the mRNA and the protein for the SGLT2 transporter. And if you focus here on the right first, what you can see is if you look at the mRNA and the protein as well, not shown in this slide, there's a marked increase in the SGLT1 expression of the transporter. Now, in this study, we didn't see an upregulation of the SGLT2 transporter. There are about 30 people we did biopsies in this study. The study to the right, this is Dr. Anna Salini's study. For those of you who don't know who Anna is, Dr. Salini is Dr. Del Prado's wife. And I'm the godfather of their children. So I'm kind of sorry we didn't get the same results because we have to sort of live in this same house together. But you can see she also found this big upregulation in the SGLT1 transporter. But unlike our study, she found an upregulation of the SGLT2 transporter. So for sure, SGLT1 is upregulated. And my guess is that probably SGLT2 is also upregulated. But now, because these transporters are upregulated, you filter a lot of glucose, but now they're taking back the glucose and they're not appearing in the urine. So we have a very sound pathophysiologic explanation as to why the glucose is being hyperresorbed. Now, what happens if I give you an SGLT2 transporter? And I'm going to schematically represent you or I. Here is the transport. We start now to dump the glucose in the urine. It's 80, and above 80, you dump all the glucose in the urine. Here's a typical diabetic, and that sort of cut point is at 220. Now, I'm going to put you on an SGLT2 transporter. What do I do to that threshold? Do I bring you back to 180? You're going to see no. Do I bring you back to 100? You're going to see no. Where do I bring you? I bring you back to a value, okay, a threshold that's lower than your fasting glucose. So if I took every single person in this room and I gave you here, we did this study originally with canagliflozin, but we've also done it with empagliflozin and dapagliflozin. The results are identical. I give anybody in this room, you will start pouring out glucose in your urine. But your blood sugar will absolutely not change. It will stay at 80. So why does that happen? So in doing these studies, we discovered a whole new physiology that people were completely unaware of. And so once the glucose starts to appear in the urine, and you start with a glucose of 80, glucose starts to appear in the urine, a signal goes through the renal nerves to the kidney, from the kidney to the liver, and the liver starts producing a glucose, which is identical. It's incredible. It's identical to the amount of glucose that comes out in the urine, and so your blood sugar level doesn't change. It's one of the most finely tuned mechanisms in physiology. And that means that you're never going to get hypoglycemia, okay? Because those renal nerves, when they get activated and send that signal to the liver, that liver is now going to turn on and start producing glucose, and it will maintain your glucose concentration constant. So this class of drugs really should be the friend of the cardiologist. They should be the friend of the nephrologist. They should think of these drugs not as glucose-lowering drugs, because as you're going to see, these drugs are very protective for your kidney, and they're very protective of your heart. So the cardiologist and the nephrologist should feel very comfortable using these drugs. They don't need an endocrinologist to prescribe them. And as you'll see as we go through this, I believe these drugs should be first-line therapy. So what about clinical studies with these drugs? Where do they fit sort of in the treatment algorithm? So this is a survey of the literature, and this is with empagliflozin. And as you know, empagliflozin comes in two doses, 10 and 25 milligrams. The 10 milligram dose is the orange, the 25 milligram dose is the red. So these are drug-naive patients, and the next group of people are on metformin, combined therapy, metformin, SU-pioglitazone. And I think we can just focus on the dark red bar. You can see there's about a 0.8 to 0.9 drop in the A1C in someone who starts with an A1C of 8. So if you start with 8, I'm going to get you down to about 7. If you want to add another drug, you'll get down to 6.5. And the beauty of this class of drugs is because they work on the kidney, you can combine them with any other drug that you like. And so these are good drugs for achieving glycemic control. Now, you're also losing calories in the urine. And these studies are really quite consistent. And again, it doesn't make any difference what the background therapy is. You lose about 2.5 to 3 kilos over the first 6 months of treatment. Now, what's interesting, after 6 months, you're still putting glucose out in the urine, but why does your weight stabilize? Julia Farinini, Professor Farinini's daughter, did actually a very nice study when she was in Sweden, showing, in fact, that what happens is that people start to eat more. And so they take in more calories. So even though they're peeing out more calories in the urine, they're taking in more calories. So the weight stabilizes. But nonetheless, you are losing about 2.5 to 3 kilos. So this is very good. I mean, this is not a GLP-1, but still, this modest amount of weight loss is good. Now, what about blood pressure? This is now change in systolic blood pressure. And you can see across the board, your change in systolic blood pressure is about 4 or 5 millimeters of mercury. So another beneficial effect of this class of drugs. So these drugs have many, many benefits. They correct this novel defect at the level of the kidney. I mean, who knew before we started doing these studies that the kidney was hyper-reabsorbing glucose? No one was aware of that. So these drugs are very, very good at lowering that threshold. In doing so, you correct the glucotoxicity, you get a nice drop in the A1C, calories come out in the urine, you weight loss. You can combine them with any other drug, because kidney drugs are different from the other drugs. They reduce your blood pressure, no hypoglycemia. So these drugs are going to be very good for controlling glucose, and they also are likely to correct some cardiovascular risk factors, and you are very likely to get cardiovascular benefit. So this is the very first of the SGLT2 inhibitor studies, and this turned out to sort of be a gangbuster study. This is with empagliflozin, and the results with empagliflozin actually, on surface, may look better than with the other drugs. But there's a reason for that. And the reason has nothing to do with the fact that empagliflozin is different from dapagliflozin or canagliflozin. The study populations are very, very different. So in the EMPA-REG outcome study, 100% of the people who got into the study had had a previous cardiovascular event. So this is a very high-risk population. In the DECLARE study with dapagliflozin, 2/3 of the people got in because they had risk factors, didn't have established cardiovascular events. So I think the differences you see amongst these drugs is got to do with the patient population study, not with the drugs themselves. But as we go from left to right, this is the MACE endpoint. This is mortality in the middle, and then to the right is heart failure. And you can see the hazard ratio is 0.86, and this is what, if you were at the ADA when this was presented, everybody was like, woo! No one ever seen a hazard ratio of 0.6 before, and same for heart failure. Now, the other very important factors, you look down here and on the x-axis, these curves start to separate instantaneously. And in fact, within 1 month, they're statistically significantly different. So now we know if people are in the hospital, say, with heart failure, we actually start the drug when they're in the hospital. We don't wait for the patients to go home. So the sooner you start, the better off you're going to be with these drugs. Now, what about hospitalization for heart failure with reduced ejection fraction? So you heard a very nice talk on heart failure the other day, and as our diabetic patients are living longer, we're seeing more and more heart failure, and this is actually becoming the dominant problem that we have to deal with from the cardiovascular standpoint in our diabetic patients. And again, you can see the people treated with empagliflozin and the Packer study in the New England Journal, again, within a few months, the curves are starting to separate, and the hazard ratio is 0.75. So this is heart failure with reduced ejection fraction. This is usually ischemically related. These people have quite significant impairment in terms of perfusion because of stenosis in their coronary arteries. The more common type of heart failure that we see in diabetic patients is called HFpEF, and again, this was covered in the presentation yesterday. So this is heart failure with preserved ejection fraction. And you can see here, again, hazard ratio 0.79, and again, the curves separating very, very early in the natural history of the disease. This is a disease mostly of, in my opinion, lipotoxicity in the myocardium and hypertension, okay? It's very different in terms of its manifestations than is HFrEF, okay? So what are the mechanisms that have been postulated? So we have a big interest in heart failure in people with type 2 diabetes. I actually have two very large NIH grants. One is to look at HFrEF, and the other is to look at HFpEF, okay? So I believe that the major beneficial mechanisms are hemodynamic. So these drugs decrease the intravascular volume. When I put you on the SGLT2 inhibitors, in the first 48 hours, you go into negative salt and water balance, about a liter of fluid and about 100 milliequivalents of sodium. So I'm decreasing the intravascular volume, and that's going to decrease both the preload and the afterload. Now, and the blood pressure, as I showed you, decreases. What's very surprising in every SGLT2 inhibitor study is the heart rate does not go up, okay? This suggests that there may be an inhibition of sympathetic tone. And in fact, that is indeed the case. The other thing that happens when I put you on these drugs is that there's a marked decrease in arterial stiffness. And this happens very quickly. And remember, the heart is not pumping against the blood pressure that's in the brachial artery. The heart's pumping against the blood pressure that's in the aorta. And there are very good studies showing a marked decrease in aortic stiffness as well as in peripheral arterial tone. And so this is now further going to lead to an unloading of the heart. And so simultaneously, you're getting decrease in preload, afterload, and inhibiting the sympathetic nervous system. And I think this is the major mechanism. Now, what is the second most important thing? You can argue that this is more controversial, but I believe it has to do to a change in substrate metabolism from burning glucose to burning ketones. So this hypothesis was first put forward by Professor Farinini at the American Diabetes Association meeting, annual one, about 6 years ago. And what Professor Farinini postulated was when I acutely lower the glucose, and in fact, this postulate is based on our work, when you lower the glucose, you stimulate lipolysis. Because if you don't have glucose as a fuel, you need to have another fuel. So glucose goes down, the insulin goes down. Glucagon goes up. This stimulates lipolysis in fat cells, and at the level of the liver, the drop in insulin and rise in glucagon converts by beta oxidation the fat cells to ketones. Ketones are more avidly taken up by the myocardium than glucose, and they generate more high-energy phosphate per oxygen metabolized. So they're a very fuel-efficient substrate. And we believe that, in fact, that this is playing a very important role. And if you read 2 months ago, the article of the month, the front page of Diabetes Care, we showed that if you take people with heart failure and reduced ejection fraction, and you raise the ketone level to what you would see after you're giving an SGLT2 inhibitor, you markedly improve all measures of both systolic and diastolic dysfunction. And we now have a 5-year grant from the NIH to look at this on a long-term basis. So we think that these are the two most important mechanisms. But there are a whole host of other things happen with these drugs, which potentially could be playing a role here. Now, I don't have time to go through all of them, but these drugs are very good at improving insulin resistance. They're very good at promoting weight loss and decreasing visceral fat. Now, this is a very interesting one that I think needs to be looked at. So these drugs activate pantothenate kinase. Now, how many of you here, without looking at that slide, know what the hell pantothenase is? Nobody, right? Okay. Well, if you had good eyes, you could see it's vitamin B. So when you metabolize vitamin B, what do you end up with? Acetyl-CoA. And what does acetyl-CoA do? It feeds into the Krebs cycle and it generates ATP. Well, you can take the isolated perfused heart, or you can take isolated myocytes, and if you incubate them with dapagliflozin or empagliflozin, you markedly increase acetyl-CoA generation. So what this is saying is this is an off-site effect of the drug. And this is actually very exciting because this is the first time anyone has really conclusively shown an off-site effect of an SGLT2 inhibitor. These drugs also activate the Ang-1-7 system, which is the good angiotensin system. They decrease inflammation and oxidative stress. They affect the sodium proton pump, and they decrease LV mass. And lastly, they increase the hematocrit. So as you can see, there are lots of potential mechanisms, but if I had to put my money on two, I would say hemodynamically and substrate shift are the two most important mechanisms. Whatever the mechanisms are, you don't die, and I save your heart. That's all good, okay? Now, what about SGLT2 inhibitors in diabetic nephropathy? So the original study was done with the Credence study, and I'll come back to that in a second. But diabetic kidney disease is increasing worldwide. If you look at myocardial infarction, stroke, et cetera, they actually have been decreasing over the last 30 years. In contrast, diabetic kidney disease has been going in the opposite direction. It's progressively increasing. And in the United States and most westernized countries, it's the leading cause of end-stage renal disease. And as I said, unlike retinopathy and unlike MI and stroke, which are decreasing, diabetic kidney disease is going up. If you're on dialysis and you take care of dialysis patients, you'll know that this is a miserable life. The patients will tell you all the time. They don't feel normal. And above and beyond that, from the cost standpoint, it's very expensive. The other thing that you need to be aware of, as your GFR goes down, what happens to cardiovascular death? It goes up dramatically. So kidney disease and cardiovascular death go hand in hand. So prevention of renal failure is, in a certain way, secondarily prevention of heart attacks and strokes. So now, the first big study was the Credence study. The second big study was the dapagliflozin study. And the third big study is the empagliflozin study. The results are all the same. I'm going to show you the empagliflozin study. Big study, 6,600 people to get in. You had to have a low GFR or an increase in the urine albumin to creatinine ratio greater than 200. And then the people are going to be randomized to empagliflozin, a placebo, and the primary endpoint is very similar in all these outcome studies: doubling of the serum creatinine, having your GFR, ending up with a death from renal disease, or ending up on dialysis or transplantation. And just like was shown in the Credence study, just like what was shown in the DAPA kidney study, the hazard ratio is 0.72. In the other studies, it ranged from 0.7 to 0.75. So again, a very effective way of slowing the prevention to end-stage kidney disease. Now, if we look at the individual endpoints in the empagliflozin study, here is the primary endpoint. I already showed you that. The p-value is less than 0.01. But if you look at progression of kidney disease, the slope of the decline, if you look at the number of people who ended up on dialysis or needed a transplant, if you look at the number of people who died, or if you look at the number of people who developed heart failure, you can see the hazard ratios are all about 0.8, and the asterisks, they're all statistically significant. So these drugs are excellent at giving you kidney protection and giving you cardiovascular protection. And in fact, if you have advanced kidney failure, you are 5 times more likely to die of a heart attack and a stroke than you are of the kidney failure. So these two things go hand in hand, and this class of drug affects both, okay? Now, what about the etiology of the kidney disease? So this is a review article I wrote in Nature Nephrology, and believe it or not, there's an ominous octet for diabetic kidney disease. I like the number 8, okay? So the most prevalent theory has to do with this deranged tubular glomerular feedback. This was originally put forward by Dr. Barry Brenner at the Peter Bedbringle Hospital in Boston. As I told you, I'm giving the Brenner Memorial Lecture this year at the American Society of Nephrology. Now, you can listen to me, or you can follow the words, or maybe you can do both. So, what is this tubular glomerular feedback hypothesis of renal disease? And it's not really a hypothesis, it's now very well established. So if you're a type 2 diabetic or a type 1 diabetic, your blood sugar is high, so now you're going to filter a lot of glucose. In the proximal tubule, you're going to take back that glucose with the sodium. That means there's going to be a marked decrease in the amount of sodium that's going to the juxtaglomerular apparatus. That's the JGA on this slide. So now the kidney is now going to be, it's going to perceive itself as being underperfused. And when the kidney perceives itself as being underperfused, it's going to do two things. It's going to cause vasoconstriction in the efferent arteriole, the little artery coming out of the kidney, and it's going to cause vasodilation in the afferent artery. And the net result of this is going to be an increase in the intraglomerular pressure, and that will increase your GFR. So the kidney looks okay initially, but that increase in the intraglomerular pressure on a long-term basis is going to damage your kidney. And what I just said is shown schematically. So there is vasoconstriction in the efferent arteriole, and I think everybody knows we're going to treat this with either an ACE or an ARB, and we're going to now vasodilate downstream. And in the efferent arteriole, Dr. Brenner worked this out, there's a decrease in adenosine. Adenosine is a very powerful vasoconstrictor. So if I decrease the adenosine, I vasodilate. So I reverse the problem here. But this is only one part of the story, okay? And I think it's an important part of the story, but unfortunately, it's taken the shift away from the other potential mechanisms. So if you really want to prevent diabetic kidney disease completely, just next bar, there it goes. If you want to prevent diabetic kidney disease completely, just keep the glucose in the normal range. We spend an enormous amount of time and money when your GFR gets to 20. Why don't we just get the A1C to 6.5 in our diabetic patients and keep it there? Then you'll never develop diabetic kidney disease. In the absence of hyperglycemia, you don't develop diabetic nephropathy. So we spend all of this time when the disease becomes manifest. We should spend more time, and we have great drugs now that we really can manifest and maintain normal glycemia. Professor Kanat, when was asked about insulin therapy, if we control our patients, then we don't need to put them on insulin therapy. Hypertension, second most important cause of progressive kidney disease is an increase in blood pressure. And we had a very nice talk the other day on blood pressure control. So let's get our blood pressure into the 120/30 range over 80. And if we can control the glucose and the blood pressure, we would obliterate probably 99% of diabetic kidney disease. Hypoxia, okay? Because you are filtering all of this glucose, and you have to reabsorb the glucose with sodium in the proximal tubule, that sodium that's within the cell needs to be pumped out. It gets pumped out by the sodium-potassium ATPase pump. That's very, very energy requiring. And it turns out, using bold MRI, we and other people have shown that the kidney is actually hypoxic. And when the kidney is hypoxic, this leads to inflammation. It turns on processes involved in fibrosis. The podocyte. The podocyte is the renal site of insulin resistance. People have been looking for what is the defect, what is the insulin resistance in the kidney. And it resides in the podocyte. So if you take an animal and you knock out the insulin receptor only in the podocyte, not in the whole body, not in the whole kidney, but in the podocyte, and you do that, you reproduce diabetic nephropathy, okay? So what is the podocyte? It sits on the glomerular basement membrane, and with the foot processes, it prevents albumin from leaking into Bowman space and getting into the kidney. But if you damage the podocyte or the foot processes, albumin gets into the tubules, and albumin is very toxic to the kidney. A lot of interest in developing drugs that work to maintain the integrity of the podocyte. This is the other big one. If you do, there's a big publication about 5 years ago from Columbia where they did renal biopsies in about 600 consecutive people who they thought had typical diabetes and diabetic nephropathy. Lo and behold, and this doesn't surprise me at all, over half of the people actually had a picture that was not consistent with diabetic nephropathy. And this has now been reproduced many times over. And so what did they find? They found a lot of things, but one of the things they found was fat in the kidney everywhere. Fat in mesangial cells, fat in glomerular cells, okay, fat in tubular cells. This is lipodystrophy, okay? You heard about fat in the liver yesterday, okay? Fat in the heart, in my opinion, this is HFpEF. Fat in your muscle, okay, that's insulin resistance. Fat in your beta cells, that's beta cell failure. Why do you think the kidney would be exempt from being infiltrated with fat? It's not exempt. So I think lipodystrophy, fatty kidney, is an important cause of diabetic nephropathy. And I believe that when we treat people with these powerful GLP-1 receptor agonists and you lose weight, you're getting rid of fat everywhere, including in the kidney. And I think that's an important mechanism by which they give you renal protection. The tubules also hypertrophy in people with diabetic nephropathy. And they secrete growth factors. And those growth factors cause the glomerulus to hypertrophy, okay? There's a well-established physical law. It's called the law of Laplace. And it says if you have a sphere, the pressure within the sphere is proportional to the radius. So if now your glomeruli expand, that's a self-fulfilling cause of increased intraglomerular pressure. And then last on the list is something we can't do anything about, genetics. Well, we can't do anything about it because we don't know what the genes are, but there clearly are genes. So if you have a person sitting in front of you in the office and you want to know whether they're at trouble for developing diabetic nephropathy, just ask them, your mom have diabetes? Yep. Yeah, what did she die of? Oh, she was on dialysis. Boom. That person's at risk, okay? So this is something that runs in families. What the genes are remain to be seen. Now, here now is the ominous octet for kidney disease, where I've now plastered it with the SGLT2 inhibitors. And you see they improve 7 of the problems. The only thing they don't correct is the bad genes your parents gave you, okay? So once you get those genes, you're kind of screwed for the rest of your life. Can't do much more about it. So this is going to be a great class of drugs for treating diabetic kidney disease. Now, I don't have, maybe next year I'll talk about diabetic kidney disease in more depth. But we have 4 classes of drugs now. We have the ACEs and the ARBs, okay, and they're very effective. We have the SGLT2 inhibitors. I've just told you they're very effective. We have the mineralocorticoid, non-steroidal mineralocorticoid antagonist, phenynerone, Canindria, and then we have the GLP-1 receptor agonist. And in my opinion, and I think this is the prevailing opinion now in the nephrology community, these are the 4 pillars, and they should be started 1, 2, 3, 4 very quickly. You shouldn't be waiting a year. Maybe I put you on the ACE or the ARB. A couple of weeks later, I come back, you're on the SGLT2 inhibitor. You come back a couple of weeks later, I add the phenynerone, and a couple of weeks later, the GLP-1 receptor agonist. Now, these are now all of the big renal outcome studies. So this is losartan. This is Dr. Barry Brenner's, the original study with losartan. This is now the relative risk reduction for developing end-stage kidney disease, 16%. So that the hazard ratio, what you're used to seeing, would be 0.84, okay? So I'm going to change this, and I'm going to give you the relative risk reduction for, I use dapagliflozin because it has the biggest one, 44%, okay? Here is feninerone, 28%, okay? Here is semaglutide, 24%. All looks very impressive, except, what did I show you? Relative risk reduction. Now I'm going to show you absolute risk reduction. Looks a little bit different. So here's dapagliflozin, absolute risk reduction 5%. The others, 2, 3%. Now I'm going to add 3.6, 5.3, 3.3, 1.7. Absolute risk reduction is 13.9. What does that say? It says 80% of the risk is still unexplained. What does that mean? It means we need additional better drugs, and or we need to be using these drugs in combination right from the beginning, okay? We probably need additional drugs, but for damn sure we should be using these drugs together in combination therapy. So if we look at the SGLT2 inhibitors, they're very good for lowering the A1C, and when I do so and get rid of glucotoxicity, I improve beta cell function, I improve the insulin resistance, I get a little bit of weight loss, I drop the blood pressure. They're good for decreasing cardiovascular disease. They're really good for decreasing heart failure. They're great for protecting your kidneys. Studies done by Dr. Kuzi show they have promise for NASH, or as I said, you can never remember these drugs. They go from NASH to MASH to MAFLD to MASLD, whichever you want to call it. They do show some promise. I'm not sure as independent drugs they'll get approval by the FDA, but they clearly have benefit. And a totally unexplored area, I think these drugs will have benefit in the eyes, and we heard a little bit about that from Dr. Malik. And you can use them in combination, and they're really quite safe. So the key message is, and this is basically the last slide, these drugs are great in controlling glucose in type 2s. They promote weight loss. They give you cardiovascular protection. They're very good in terms of treating and preventing heart failure. They're excellent in terms of slowing down the disease in the kidney. And so they're good for everybody. They should be first-line therapy, along with, you know, my biases, pioglitazone and GLP-1. And importantly, they are the friend of everybody here, okay? These drugs are incredibly safe. They cannot cause hypoglycemia. So they should be used by primary care. They should be used by internal medicine doctors. They should be used by endocrinologists. They should be used by cardiologists. They should be used by nephrologists. There's no reason in the world why you should not be using these drugs. You do not have to be an endocrinologist to prescribe these drugs. So that's the last slide, and I'm happy to answer questions that people might have.